Hello, everyone. So the title of my talk today is on clinical and genetic aspects of TBRS. I'm a clinical geneticist at Washington University School of Medicine in St. Louis, Missouri. And I would like really to start the presentation by presenting two patients that I've seen here in the clinic at WashU. The first patient is now 14 years of age, who was initially evaluated in infancy for decreased muscle tone, delayed milestones, overgrowth, macrocephaly, and some facial differences. He was born at term after uncomplicated pregnancy and started exhibiting delayed milestones, which he continues to have until this time, requiring therapeutic services. His formal testing, IQ testing, revealed moderate intellectual disability. He now can speak in short sentences and participate in social situations. He is described as very friendly. He attends now 7th grade on special education classes. His past medical history is significant for 2 episodes of febrile seizure, hernia repair, and repair of undescended testes. He underwent a placement of ear tubes for recurrent ear infections, underwent tonsillectomy due to abnormal sleep study. A repeat sleep study at the age of 13 years continues to show obstructive and central sleep apnea requiring CPAP. He is followed by orthopedics for flat feet, which required 2 surgical interventions. His brain MRI showed Chiari malformation, and his family history is unremarkable. He has 2 healthy siblings and healthy parents. His physical exam at the age of 13 years revealed his weight and the height as well as head size all are greater than the 99th percentile. He has some facial differences, including mild coarse facial features, with bushy brows, deep set and down slanting eyes, flaring nares, long and smooth philtrum, thin upper lip, incisors were big, and he had posterior rotation of ears as well as a broad forehead. He has hyperflexibility in his joint and interphalangeal joints. He had mild generalized hypotonia, hirsutism on his back, and low posterior hairline, as well as flat feet. These are his main facial features. You can appreciate their deep-set eyes, the bushy eyebrows, the smooth long philtrum, thin upper lip. You can appreciate also the large upper incisors. And this is when he was a little bit older. You can appreciate also some of the facial features that I mentioned before. More clear in this picture, you can appreciate the deep-set eyes, the bushy eyebrows, the broad forehead, and the macrocephaly. His clinical exam sequencing revealed that he has the mutation at position 882. This is an amino acid change of arginine to histidine in the DNMT3A gene. Targeted testing of the same mutation in buccal swab and the scan demonstrated the presence of the same mutation, indicating that this is not limited to the blood. This is what we call a germline mutation. Since this mutation was described to be very frequent in different types of malignancies, especially in leukemia, we recommended to repeat a blood count with differential every 12 months. He was enrolled in the research study through Dr. Tim Lay lab and to do whole genome sequencing, and I believe Dr. Lay will elaborate on his research. My second patient is a now 4-year-old female who also presented early on at the age of 4 months with decreased muscle tone, delayed milestones, as well as facial differences. She was born large for gestational age, full term after a pregnancy complicated by gestational diabetes. At 20 months of age, she exhibited significant motor and language delay, for which she continues receiving therapeutic services. Her cardiac evaluation revealed atrial septal defect, and she was found to have also central sleep apnea, and there were concerns for aspirations. She has mild scoliosis, and her ophthalmological exam revealed astigmatism. Her physical exam at the age of 20 months revealed that her weight at the 37th percentile, her height was at the 85th percentile, and head circumference at the 90th percentile. She also exhibited, like our first patient, coarse facial features, deep set and down slanting eyes, epicanthal folds, short and anteverted nose, small jaw, thin tinted upper lip, as well as deep narrow philtrum. She also exhibited hyperflexibility of her knees and generalized hypotonia. You can appreciate here the remarkable similarity with the first patient, the deep set eyes, the bushy eyebrows, the deep philtrum, the short anteverted nose, and this is the nice families of the two patients that I'm presenting here. We have an update of this patient at the age of 4 years. She continued exhibiting significant central apnea. She had no change in her umbilical hernia. Her left foot started to turn in, and she was noted to have tight Achilles. She walks very short distances with a walker, and she would need actually a wheelchair for long distances. She has difficulties with using utensils, and she can say 30 words and use about 20 signs. Her genetic evaluation, including exome sequencing, which revealed exactly the same genetic change that we discussed before. This is a change at position 882 of arginine changing to histidine. And because of the concerns that we mentioned before, she was enrolled actually in the research study run by Dr. Timley. So let's talk about, I'm going to focus on the clinical aspects and the genetic aspect of this condition that is called actually the TBRS, or the DNMT3A overgrowth syndrome. So let's talk about the background about this condition. The first time that it was described, it was actually a description of kids with 13 kids with overgrowth associated with intellectual disability, and it was first described in 2014. And up until now, there are more than 90 individuals have been reported in the medical literature. It is caused by de novo, brand new genetic variants or mutations in the gene called DNMT3A. Each individual carries only one genetic variant in one of the two copies of that gene, and we'll talk about this in a little bit more details. This is the distribution of the mutation that were described so far among different individuals. So first of all, you can appreciate that the most common type of mutation, this is what we call a missense variant or a missense mutation, which means a change of one amino acid to another amino acid there. Please note also that this is these mutations are concentrated on the critical domain of the protein. Note also that the mutation that I mentioned that was found in the two patients that I presented at position 882 is found in about 15% of all patients with TBRS. There are mutations, other types of mutations, including in frame deletion, frame shift mutation, and the stop gain mutation, as you can appreciate in the lower part of the figure. Let's talk about the genetics of this condition. So this is what we call an autosomal dominant condition, which means that you have one mutation only. In 98% of the cases, this is a de novo brand new change It is not inherited, but in about 2% of the cases, it is inherited from one of the two parents. If neither parent of a patient has TBRS with negative genetic results, the risk of having another child with the same condition is very low. The estimation is now is less than 1%, and this estimation is based on the fact that sometimes one of the parents may have germline mosaicism. But the risk to children of affected individual is 50%, a chance of having a child with TBRS. Let's talk about the main clinical findings of TBRS. So as indicated and was illustrated in the two patients that I presented, the most common finding is really delayed milestones and later on intellectual disability. There is a spectrum of severity that can go from mild to severe, but the majority of patients exhibit moderate degree of intellectual disability or delayed milestones. They have a higher ability in their verbal skills as compared to nonverbal reasoning ability. The majority of patients exhibit impaired adaptive functioning. This is less obvious in adults. This can be related to the fact maybe adjustment, maybe receiving therapeutic services, but the good news is that it's not getting more severe over time. There were cases that were described with the regression in the milestones. Interestingly, that lower intellectual ability and adaptive functioning were associated with a greater severity of the autistic traits. Almost all patients require some degree of support in the mainstream school or in living with, they would require support in living as adults. Behavioral and psychiatric problems were described in about 50% of the cases, and this would include autism, anxiety, aggressive outbursts, ADHD, psychosis, schizophrenia, and bipolar disorder. Autism found to be the most common prevalent co-occurring diagnosis with TBRS. It is found in about 30 to 50% of the patients. The second finding that I would like to discuss with you, this is the overgrowth, which is found in the majority but not all patients. The estimation based on the reported cases, it is found documented in about 85% of the patients. And the definition of that the height and or the head circumference equal or greater than 2 standard deviation above the mean. There are different definitions, but I would adhere to this definition. Obesity is also common. It is found in about 2/3 of the patients. Many patients are born with overgrowth, and they are large with large birth weight. Facial differences are very common. As a clinical geneticist, I can tell you I can recognize these facial features, so I would consider this condition as recognizable in certain patients, but not in all patients. So you can appreciate in a few patients, there are what we call long face, other patients with round oval face, a broad forehead. This is a common feature, horizontal, thick eyebrows. You can appreciate that. Large upper incisors, what I mentioned in patient one in the two patients that I presented, or a crowded teeth. Coarse facial features also is very common. Deep set and occasionally down slanting eyes also are seen. The philtrum, which is the area between the tip of the nose or the base of the nose and the upper lip, can be either smooth or deep and can be long with thin upper lip. Additional common clinical features would include decreased muscle tone, hypermobility in different joints, especially in the large joints, but also in interphalangeal joints. Umbilical hernia was described in a few patients. In 20% of patients have cardiac abnormalities. These are mostly congenital cardiac defects. Recurrent infections, especially in the upper airways, and lung infections. More recently, we realized that an autonomic dysfunction is a common feature, and what we are referring here to what we call postural orthostatic hypotension. Sometimes you can see also episodic vasomotor instability with the differences in the color based on exposure to cold weather, a poor heat intolerance or tolerance, decreased sweating, and high pain tolerance. What we emphasize also in our two patients, central sleep apnea is also under this category of autonomic dysfunction. Other common features, seizures were described in 25% of the patient. This can be related to fever or without any relation to fever. Brain imaging is generally normal, but non-specific finding, including large ventricles and Chiari malformation, can be found. More and more, we realize that orthopedic abnormalities, including scoliosis, including kyphosis, these are spine abnormalities, can be found in many patients with this condition. Tapering fingers also are very common. More and more, we realize that foot and toe anomalies are common features as well. And descended testes were described in about 10% of patients. One of the major findings that we see among patients, or this is rather, I would say, this is a hot topic in the field of malignancy. This is the association of the somatic variants as compared to the germline variants in the DNMT3A gene. So the difference that with the somatic variant, if you check, for instance, if you have leukemia, you can find the mutation limited to the blood cells that caused the leukemia. If you check other tissues, you wouldn't find that mutation as compared to the germline mutation, where the mutation is found in every single cell in the body. So the appreciation of the significance of this gene in the as a drive for the development of adult AML, acute myelocytic leukemia, or MDS, myelodysplastic syndrome, is really is growing. It is found in greater than 50% of the variant, and greater than 50% of the variants are a change in the amino acid arginine at position 8A2. Interestingly, acute AML was described so far in 2 children with TBRS, one of them with a mutation at the position of the arginine 8A2. 3 patients were reported with brain tumors. 1 patient was reported with neuroblastoma, and 1 patient with pituitary adenoma. The estimation based on all the cases for malignancy is about 7.5%. Nevertheless, there are no established guidelines or protocols to do surveillance for patients at least at this time. So the question as a clinician, how we can establish the diagnosis. So 2 cardinal features of this condition are the overgrowth and intellectual disability. But this is not enough actually to make the diagnosis. You need also evidence or a genetic evidence. And what I mean by that, you need to show that the patient with the overgrowth and intellectual disability has also a pathogenic variant in the DNMT3A. Why is that? Because there are many other conditions that we call overgrowth under the category of overgrowth intellectual disability syndromes that would exhibit very similar findings, such as Sotos syndrome, but they have mutation in a different gene. What I mentioned to you regarding the additional findings, all of these are supportive for the diagnosis, but are not cardinal to make the diagnosis. I would like to acknowledge the parents of the 2 patients that I presented here, and the families of all patients who contributed actually clinical information, pictures of their children. to teach the medical community and to advance research into this genetic syndrome. Thank you very much for listening.